people are still kind of trickling in, so we'll sort of slow roll our introduction a little bit. There are 3 of us here, but there are 5 of us total whose work is represented. 2 of our co-conspirators couldn't join us in person, but have definitely had their hand in developing this this presentation. My name's Meredith MacMartin. I'm a palliative care physician at Dartmouth. Michael Rubyan is a health services researcher here at University of Michigan, and Christina Penfield is a maternal fetal specialist at NYU. So we kind of have a nice broad spectrum. And then our absent colleagues, Stijntje is a MD PhD, so she really has a foot on both sides of clinical practice and research. She's a radiology resident in Rotterdam, Netherlands. So it's a big trip for her to try to attempt. And Alexis Steinberg, our 5th member, is a neurologist and neurointensivist at Pitt. So what we're going to try to do here is to build a bridge. Brian's like nodding his head like he recognizes this. I always like to try to add a little something from where we're presenting. So this is a lovely arched rock from Michigan, Mackinac Island, I think, if I'm correct. And it's quite famous, and there's a lot of beautiful photos and actually a really nice WPA style poster, which I was tempted to include. But this is the photo, and what we're really trying to do is we're trying to sort of connect the academic research side with what's actually happening clinically, and to think through some of the challenges around implementing some of the decision tools that our research colleagues work so hard on, and also to think about ways that we can support, as clinicians, support the development of tools that are actually going to get used and implemented in a useful way. So to start off, I think other crosstalk sessions have done this, but we're going to follow the trend. I would love for people to raise their hands if they're primarily a researcher. Oh my gosh, okay, nice. Great. Okay. Please raise your hand if you are primarily a clinician. Okay, all right, so mostly researchers in this audience. This is great. So I want you to do a little bit of thinking, let's say in the last month or so. Think back on a decision that you've made in your life, right? This might be a big decision like buying a car. Might be a small decision like where are we going to go out to dinner, or what hotel am I going to stay at when I travel to Ann Arbor? So raise your hand if you did some research to help you make that decision. Okay. Raise your hand if you talked to trusted people to get advice or input about that decision. Okay.
I trusted them when I started.
Fair. Raise your hand if you did none of those things and you just did it on your own. Okay, so right, that's how we make decisions. There's not a lot of clinicians in the room, but I'm curious for the clinicians who are here, think back to maybe the last time you were seeing patients. If you're an inpatient doc, maybe last time you were on service or last time you were in clinic, and about a medical decision. How many of you used any kind of decision aid? Just like a patient-facing decision aid, risk calculator? Christina did. I did not. Okay. How many clinicians maybe talked to a trusted colleague, called a consult, curbsided somebody? Yeah, pretty common. How about any clinicians who, welcome everybody, please come on in, who just made the decision on their own, totally in isolation? Sometimes I do that, right? So I just want us to remember, like we're humans and we make decisions too. And the same sort of paths and processes that we use to make decisions really apply to patients and families. And it's the same thing, right? Decisions are decisions. There's lots of different information and different parameters, different consequences, but choice is choice. So we're going to talk a little bit about decision tools. And just to sort of set the frame for what we're talking about, we're not really talking about clinical data, right? So lab tests, radiology results. What we're thinking about are tools that help us make sense of data, share it in a way that feels useful, and ultimately help people make decisions that feel good. So these might be shared decision-making aids. These might be computerized decision support systems. So Stijntje, one of our colleagues, has really worked very hard on this pretty beautiful radiology tool that's embedded in their electronic medical record to help guide choice making around what radiology study to order. These might be decision analytic models that help with things like prognostication and clinical decision rules and guidelines. And so just to sort of think, this is very simplified, but this is a little bit how I think about it. What does it mean to make a good decision? This is like maybe at least, if not the $1 million question, $1 million question that I've heard discussed a lot this week. It's one in which the patient or decision maker is adequately informed about their options and gets the option that best fits their values and preferences, right? There's a lot that goes into this. We'll talk more about that, but sort of boiled down, this is how I think about it. And the question is, what are those options? How likely are the outcomes for each of those options? What are their values, right? There's a lot that actually goes into it when we're drilling down on it. So I'm going to give you a couple examples from my practice. I'm a palliative care doctor. Lots of people perceive that this is what my job is. I'm sort of the Dr. Death. In fact, that is not the case, but Alexis had this in a slide deck, and I just love the picture so much that I really feel like I'm going to keep it forever. So we don't only see patients who are dying, we see people even quite early in serious illness, ideally. Palliative care is also not just about holding hands. Palliative care clinicians, if there's any in the room, will recognize this. This is a sad hands collage. If you Google palliative care and do an image search, you're going to see a lot of sad hands. And sometimes I do hold my patients' hands, but it's more than that. Really what it's about is about helping people make sense of what's going on and chart a path forward. And it's often very complex. And decision-making is actually a core component of interdisciplinary palliative care in our clinical practice guidelines. This is like bread and butter for us. So we're going to start with a case. This is actually my husband, who fortunately is not the patient in this case, but I needed an exemplar photo. So we're going to start with a case. 39-year-old, previously healthy man, found down at home in a cardiac arrest. And EMS is called, brought to the emergency room, pretty prolonged CPR, and ultimately has return of circulation, ends up in the critical care unit, and has a pretty significantly impaired neurologic exam, sort of brainstem reflexes, but otherwise not waking up, not making meaningful progress towards consciousness, and needing a lot of other support besides. What should we do? And this is the kind of consult that we will get quite frequently as palliative care doctors. People will call us and they're like, it's not going well. We need help. So if we think about what's a good decision, right? Patient and decision maker are adequately informed about options. But really, what decision are we even talking about in this case, right? There's a lot of potential choices. There's lots of medical decision making that's happening. Things like titrating pressors and ventilator settings, and lots of manipulation of clinical data. And then there's sort of the big picture of where are we going with this? Is this care that this patient would want? But often we don't even get an explicit decision. When palliative care gets called, we get called and people say like, it's not going well. And it might be because the team has a sense that it's not going well. The family may come to the team and say, this doesn't feel right. We really need to kind of take a step back. So one of the first things that we're often doing is helping to articulate what are the actual choices that we're talking about. Are we talking about de-escalating care and allowing a natural death? Are we talking about a tracheostomy and a feeding tube to allow for maximum rehab? What are we even talking about? So in this case, thinking through what are the options and what are the expected outcomes of each option and how likely are they? We've got to think about what are the viable medical options here. And that's a really sometimes tricky thing to do in patients who are really complex. Anybody in the ICU is automatically really complicated, and there's a high degree of uncertainty. And there are decision-making aids that can help us with things like prognostication. How likely is it for this person to wake up? How likely is it for them to get back to a quality of life they would find acceptable? But they're statistics, and often I think clinicians feel like they fall short because of the high degree of complexity in the neuro ICU, especially. So that's a place where there's lots of decisions, but we don't have a lot of great tools to fall back on. This is what we call a co-produced decision, right? What is the choice? What are the options, and how are we going to actually talk about this? And so this is a time when we would sort of actually start with what are the goals and values, and who is this person and what's important to them, and then work backwards from there to start thinking about what decisions there are. And so it ends up getting flipped a little bit. There's no great decision aid for that. The second case, this is my grandfather. His name is Dick Lamberts. And he was a very fiercely proud and independent man. He was a professional athlete, golf ranger to the Bushes, who were like his all-time favorite people. And I did think about putting a picture in, but couldn't bring myself to do it. My grandfather had very significant visual loss from macular degeneration. And also very significant hearing loss. And so in his later years, his ability to interact with the outside world just got smaller and smaller and smaller. And then he fell and broke his hip when he was 86. Got it repaired, rehabbed, but never bounced back, which is pretty common. Anybody who is taking care of patients like this knows that that's pretty common. And really in the year or so after he broke his hip, he was in and out of the hospital a lot. And we were starting to have conversations with him about, like, does it still feel safe to be at home? How's this going? His wife was also pretty elderly. They were in their house, which was not set up well for them. So there's a lot of worry about that. And in and out of the hospital, he was mostly electing to be DNR. He was having, stays of maybe 3, 5, 7 days, coming back home, losing a little bit more function every time. And in March of last year, he got really sick, and he ended up in the hospital. And my mother met him there, and the doctors, asked him about his code status. They was like, I see you've been DNR in the past, and I would recommend that. And he said, no, I want everything. I don't want to die. And it's because he knew he was going to die, and he was scared. And he died actually that night. He lost his ability to interact, and my mother changed his code status, and he was able to die gently. But that's an example of a decision where there are decision aids to guide decision-making. But it wasn't about information. He was afraid. It was an emotion. And I have not seen any sort of decision-making tool other than a person helping people sort through these kinds of decisions, because people are complicated. And I think when we're talking about decision aids, we're talking about data, and we're talking about information, and we're talking about rational choice making, but people are human. My grandfather was scared. He was a human. And so it's a place where all of the decision making, right? We could have done a go far score. What's your likelihood of getting back home if you have, right? That wasn't what he needed. He didn't need any data. He needed someone to hold his hand and tell him it was okay. So I share that to really, I think, start to open our minds around what does it mean to make decisions and how we help people to make decisions. And sometimes data is the right answer, and thinking about how we help people understand what the options are and what they mean is the right answer. But sometimes it's actually not the right answer. And so the best way we can help people with decision making is by tending to them as a human being, tending to their emotions, thinking through what they're worried about, what are they hoping for. And I think as a clinician who lives in a space where I'm sort of mired in people's emotions all day, every day, that's what I want to do as a doctor. Being a good doctor to me does not mean sitting down and giving people numbers. It means talking to them as a human. And I think there's a real danger to over-reliance on data and decision-making. And I wonder, I don't know, but I wonder if sometimes when we come up against resistance from clinicians around implementing some of these decision-making tools, whether it feels like that's part of the resistance, is that they want to be able to have a conversation with their patients, and maybe all of this data and the numbers get in the way of that. I don't know, but I'm curious. So I'm going to stop there, and we're going to switch over, but I want to give people a couple minutes to ask questions, respond. I would love especially to hear from researchers. I'm curious about whether these sorts of use cases are things that people are talking about studying in terms of quality of decision making when we're thinking about high stakes emotional decisions, and would love to hear ideas. Like, how do we do this better?
I'll be the runner. Brian.
So Brian Zickman-Fisher, University of Michigan. What strikes me as you were talking about, like, what would a decision tool to have the conversation you want to have, like not so much the data, is, yesterday we saw, not yesterday, Monday, we saw multiple examples at this conference of situations in which what was really needed is windows into experience. Mm-hmm. That is data, but it's not quantified data. And I do think that there's, from a researcher standpoint, there's things that we can do to think about the complexities and the multiple types of data that are relevant to decision making. It's easy for us to do the statistics and to come up with those numbers, but there's a middle ground between, not maybe middle ground, but like sometimes the data is what's needed. Sometimes this is what it would be like, or this is what you ought to think about is data too. And so I encourage us all to sort of reflect upon when is data the right thing and when is it not.
Yeah, thank you.
I'm Joy Butler. I'm at University of Utah and Salt Lake City VA. So we've been doing a lot of work where we're looking to collect data about what matters to patients for incorporation in the EHR and other things, and aligned with some of the ideas around the age-friendly healthcare system. I think that's the kind of information that we need in these situations, information about what matters. And there's still a lot of there's just a ton of work to do around that.
Yeah, I think there is data about what matters to people and what people's experience is, and I think that is really helpful to collect. And right, sometimes you need somebody sitting at your bedside saying, like, I hear that you're really scared about this, and we're going to find a way through it together. Yeah, we'll do one more comment and then we'll switch over.
Thank you so much for proposing this idea of the emotions, because I think people have gotten to know me at this meeting. I'm a big prom person, and we have these domains. We have mental, we have social, we have physical, and to me, those are the things that people, various people prioritize different things they want out of life. And I think, kind of incorporating all the methods we have here and the quality of life, and I've struggled with, is a decision aid or a decision tool the right thing? Because it is so complex, but if we had these measures or tools that we were already collecting for other reasons, how can we use the data we already have to then help guide people with their decision making? And so thank you for doing this.
Thank you.
Okay, great. Hi, everyone. So as Meredith said, I'm Christina Penfield. I'm a practicing obstetrician. I focus on high-risk pregnancies. So we like to joke that I'm like life and she's death. But so we're going to switch gears a little bit. But it's actually very similar. We found a lot of overlap. My other, disclosure is that I'm in the first year of a K award, also focusing on how we can optimize clinical decisions in obstetrics. But today I want to focus on a clinical decision that we and patients make in obstetrics. Maybe some of you have faced this decision yourself, if you want to raise your hand or anything like that. Maybe you've been a partner to someone facing this clinical decision, or a friend who someone has called as they're debating this. But here is the scenario. So a patient is pregnant, and this isn't their first pregnancy. They had one or many before, and one of the prior pregnancies, they had a C-section. So now in this pregnancy, we're going to think about how we're going to deliver the baby. So we have the clinical decision, and it's between either a planned cesarean delivery, so that's where you book a date, time, you show up, you go straight to the OR. That's called a repeat cesarean delivery, a planned delivery. The other option that patients face is to attempt a vaginal birth after cesarean. And this is called a VBAC. So it's pretty well known that vaginal birth has some of the best health outcomes for both the patient and the baby. This is also true for VBAC. So with a vaginal birth after cesarean, there's a shorter recovery time, less complications, and also less risk for future pregnancies. But it's very different when you have a scar on your uterus. The process of labor, there's tension and pulling on that scar. So you can have one complication that's usually talked about the most, is the famous one, is uterine rupture. So that's where the scar can actually open in labor, and this can lead to very devastating consequences. So hemorrhagic shock, the baby has no oxygen. This is very high stakes. We are talking about life or death here often when this happens, but the good news is it's very low probability outcome. But there's one other thing that is really important to consider when facing this decision, and that's when someone decides to labor and with a scar, and then the labor is not successful. And so now they have to have another cesarean delivery. This would be a failed VBAC, it's referred to. And this C-section is a totally different flavor than the repeat scheduled C-section I was talking about before. And as a practicing obstetrician, I can tell you this is like a palpably different C-section. You have distortion of the tissue planes from the scar tissue exactly where they went in last time. You have swelling of the uterus from the labor process, the fluids, the heads down there. It's very complicated. They had ruptured membranes, so the bacteria is coming up from the vagina, spilling into the abdomen. It's a very complicated C-section, so this is a huge concern. Now, it's not life or death, so I'll call it medium stakes, but it is a higher probability, right? A lot of these people did not succeed in labor before, and now they're trying it again. So it's definitely something worth considering. And so I'll just kind of paint this picture even further, thinking about the outcomes that people face based off how they give birth in this scenario. So we'll think about maternal morbidity, which is something we talk about a lot in obstetrics. It includes things like bleeding, transfusion, infection, sepsis, wound infection, maybe blood clot. And so if you are successful, like we said, vaginal birth is best. VBAC has the lowest risk, health risks. Repeat cesarean, you'll be like, it's only 4%, like pretty similar. But remember, maternal morbidity is not including exposure to opioids and longer hospital stay, future risk in other pregnancies. So this isn't totally comprehensive. But still, the main idea is that the successful VBAC is better. And overall, they're not, so different. But if this will advance, there we go. Let's think about that failed VBAC that I described. And we see it's a 17% risk of maternal morbidity. So this is, a pretty pronounced difference. So it becomes clinically relevant to then think about which category is this patient going to land in, and try to predict their chance of successful VBAC. So here it is. So they created this calculator to predict the success. So there are some demographic features here, some obstetric, historical facts from the prior pregnancy. All of this can be calculated in the clinic visit before you ever hit labor and delivery. And the idea here is to use the probability of VBAC success to guide patients and providers toward a decision that optimizes their outcomes. Seems like a good idea, right? But the question becomes, what is a good, what is a good score? What is a bad percent chance? Prior research we don't need to get into had kind of set the risk threshold at 60%. Okay, so what does that mean? If somebody gets higher than 60%, they are more likely to have a good outcome with VBAC compared to, and good outcome, right? Like we're talking about morbidity here. They're likely to have less health complications than if they did that repeat scheduled C-section. If their score was lower than 60%, then they may be having more complications with a VBAC than the repeat cesarean delivery. So this was published in 2007 with, and I forgot to say, it was with a nationally representative, all the things you'd want, huge cohort data, validated, checked, and the implementation was a success. I know a lot of you are probably working on models. This is your dream. I mean, this is total success. It was accessed through apps on the phone. The NIH had a website that hosted the calculator proudly. It was discussed in our national guidelines on VBAC, and it really became part of the culture, part of this standardized expectation in the counseling note for the prenatal visit, that score was in there and that you told the patient about the score. But then the controversies, maybe some of you are aware of these, but we'll talk about 3 of the main controversies. How did this go wrong? And there we go. The first one was an improper implementation. I'd consider this a total backfire. This calculator was just supposed to be one little innocent data point, like where do we lie on the general spectrum for successful VBAC? No, it was weaponized. Some hospitals, I never experienced this personally. I actually had to read about it to be like, what? But some hospitals developed policies restricting access to VBAC based on the calculator's predicted success. So patients could not have a VBAC unless their score was 60% or greater. So yikes, that was not an intention, but it was definitely something that was happening. The second issue was improper use of race as a predictor. So Black and Hispanic patients are automatically given a lower predicted success solely based on this variable. Let me show you what that means. So let's imagine a patient is 31, 5'4", 130 pounds, prior pregnancy, she dilated, she actually made it all the way to complete dilation, she starts pushing, but there's no descent. Hours and hours pass, no descent. Has a C-section. She's pregnant again, thinking about vaginal birth, and let's just say in this first example, she's white. Calculator says 64% chance of succeeding in labor. So her best health outcome, right? We're saying if she's debating repeat C-section or VBAC, the calculator would say you should probably favor VBAC because you're likely to be successful and the risk of complications overall then will be lower. So this would be a good candidate. But if we just change one variable on the calculator, when we flip African American to yes, it's now a 48% chance of success. So now this is an unfavorable candidate where maybe a repeat C-section should be favored to optimize outcomes. As you can imagine, this generated a lot of controversy. As the lower rate of predicted VBAC success in Black and Hispanic patients is more likely due to structural and system factors than inherent biologic characteristics of the patient. And there's a lot of concern that this could lead to Black and Hispanic pregnant people undergoing repeat cesarean deliveries that may be undesired or clinically unnecessary. And this is a big deal. We're already having a problem with C-sections in the US. Way too many. We're overusing that procedure in general, and there's disparities. And there was a concern that using the calculator would only exacerbate those health disparities. The third issue is a total lack of consideration for patient preferences and values. And this is kind of what Meredith was getting at too. They did focus groups looking at how patients were reacting to use of the calculator in the clinical setting. And the good news is patients were worried about the same thing. They don't practice obstetrics, but those 3 columns they had already imagined. And they were like, am I going to be successful? What is my chance of success? But, and this is an important but, they cared more about their experiential knowledge. And this is also kind of what we're saying. They were like, I don't care what that stupid calculator says. I know what I experienced and I know what I want to do. So it became irrelevant. And I have to say, as a OBGYN, this is what I see as well. I mean, the patient's birth experience, positive or negative, has a huge impact on how they face medical decisions. And so essentially, we made this beautiful calculator, validated, implemented, but patients felt it was reductive, not applicable, and even discriminatory. Race we discussed, but also BMI was in there. So what have we learned, or what are we learning? Is thinking about how to make tools that are useful and have a positive force in the clinical encounters. What are 3 lessons? The VBAC calculator, I think it was an issue that it was a tool without an instruction manual. There were no instructions on how to contextualize the score in patient-led approaches. The way I described it to you, but this is compared to doing a repeat C-section. Honestly, I don't even know if all the OBs understood that's how to use it. They just knew good candidate, bad candidate, and black or white. So people didn't really understand. We've talked a lot about, making sure that people know how to use and implement the score in the course of the conference. And so this is a really important piece that I think was missing, how to use, apply, and interpret it. And then the other part is really important. I asked one of my mentors on the case, actually at SMDM, former president. I told him, we're talking about the problems when implementing tools in practice. And he said, you need to tell them when not to use the tool. We need to be explicit with the limitations, when it does not apply and when it should not be used. And I think that's an important thing for us to remember. The use of race in predictive models can be problematic because disparities from the past will then be recycled into future decision making and only perpetuate those disparities. I heard the keynote speaker, I wasn't here for, unfortunately, really delved into this, and I'm so glad to hear it, and I wish I was there to hear it. But that's really, another thing. Actually, this is another example of a similar scenario. And so then again, if we're thinking about including race into a clinical decision tools, we have to ask ourselves 3 questions and really try to have some intentionality with it. I think she also included this. So sorry for the repeat, but maybe someone else missed the keynote. These 3 questions are from an article from a pulmonary critical care doc that published the commentary in New England Journal a few years ago. So, is inclusion of the race variable based on robust evidence and statistical analyses? Is there a plausible causal mechanism for the racial difference that justifies the race adjustment? And would implementing this race adjustment relieve or exacerbate health inequities? And that's what we talked about a little bit. We're already having a problem with cesareans. So if the tool is only exacerbating the inequities, it's a huge concern. Okay, and then the third and last thing would be about incorporating patient values and preferences into decision tools. And this is something that I've heard repeated, and definitely a theme that we all discussed in all of our sessions leading up to this, that really decision tools take this one-size-fit-all for the average patient with the average preferences. And it's really just makes the clinical encounter, it feels irrelevant to the clinical encounter. And we all know as patients or clinicians that clinically similar patients will have different preferences. So then their therapies will also differ. And so thinking about VBAC again, a 60% risk threshold, what was that even taking into account? Just morbidities, right? Just maternal morbidity. Well, there's so much more when thinking about a birth decision, a death decision. There's so many trade-offs that aren't accounted for in this, and it really may not be concordant with the patient or provider's preferences. And so, moving forward, it's really essential to incorporate the patient's experiential knowledge, values, and preferences into everything we do. That's the end.
Comments, questions? This is on. Yes, I think so. Yeah.
Sorry, I didn't know we were doing Q&A. I can give you this one.
I can just talk really loud.
Yeah.
Oh, there we go. There we go. All right. Aaron Shear, University of Iowa, and this is actually for both panelists. One of the things that has been touched on is the role of emotions in decision making. And in psychology, there's this thing called the hot-cold empathy gap, where we're super bad at predicting like the influence of things like emotions and our visceral states on our, the way that might change our preferences. And a lot of times, when it comes to, decisions around, our, babies and as well as end of life stuff, we're asking patients or, and their, people who are making decisions with them to make these decisions in these very cold cognitive affective states. And ideally you think, well, they're more rational then, they should be making decisions on these states. But I was wondering your thoughts on the extent to which that's actually the optimal outcome, way of making decisions versus in the moment making decisions where you are kind of, having those strong emotions and feelings and, experiences. And so, yeah, I just want to kind of open up. It's kind of a philosophical or bioethical issue in terms of what's the optimal time to start having these discussions about these things.
I think to summarize your question is sort of, we want to respect emotions, but also can they bias someone or something like that, which we face a lot in obstetrics, like consenting someone for a C-section during an emergency or like a vacuum or a forceps, like someone's pushing, like can they consent? Can they make a decision? Is that kind of what you are referring to? Or
I mean, that's the question,
whether we should.
I think emotions are biasing in a bad way.
Can they, right, yeah, can they bias in a,
Actually,
I see.
If that's a good decision making.
Yeah, I think it's a great point. And this came up on yesterday in one of the sessions. If there's an area of conflict where the optimal outcome conflicts with the preference, so they're basically, so if somebody had, say, a 20% risk of successful VBAC, and that was pointing towards a negative outcome, like should that be a valid, like, and it's because they said, I felt out of control, or I don't know, they had some just emotional thing. And that's, I mean, I think that's a really good point to think about. And I think it matters what the decision is. Meredith and I also talked a lot about this, that, what is a good outcome for birth? Is it that someone felt, good, heard, respected? Those sometimes do weigh almost as heavily as, and I had a C-section and I had a transfusion. But sometimes what I hear patients describe is sometimes those can actually be equivalent things. Even if they had a good obstetric outcome, they had a terrible birth experience, and that will still weigh so heavily. So we can't really say, as far as like birth satisfaction sometimes is, some things can be equivalent in value.
One more.
Yeah.
Time at the end.
I just want to bring up, in this context, one of the things that you really highlighted is that question of the 60% threshold. And we can argue about where that threshold should be, and maybe it's preference sensitive. Different people would put a different threshold. But I want to challenge the idea that the way the underlying data should be used is as a binary threshold question versus a trinary. We're going to recommend here, we're going to recommend not here, and we've defined the space of preference sensitive decision making. There's been a number of other talks at this conference that used that sort of three groups.
The zip I saw yesterday.
I really, it seems so obvious looking at this. Like, why isn't there a sort of like here in this space we need to talk kind of thing? And what I'm taking away from this is how common it is in the implementation of these tools that the user ends up just sort of saying, okay, well, we got to draw a line, and how dangerous that intention to draw a line, regardless of where that line gets drawn, might be on the way in which this gets used.
Thanks.
Okay, we have one more. Then we'll have a chance to stretch out and kind of talk a little bit more as a group. Okay, I'm going to advance. So I'm going to pivot a little bit here. I think this is we intentionally set this up to Meredith set us up with a kind of the framing of this. Christina set us up with kind of an example, and I'm going to now take us into discussion about the development of a tool. And I think a lot of the things that Christina just touched on, you'll see here are connected to how these decisions got made and how we developed this. So clinical context, let's start there. So we're going to be talking about surgery. I'm not a surgeon. You would not want me to operate on you. But a lot of my work as an implementation scientist and a health communications, health services researcher really focuses in that space. I'm a filmmaker originally, which kind of brings me that communication spark. And so a lot of what I do is think about what considerations we need to take into account and how we can kind of build a robust tool. And what are all the pieces of the story that need to be accounted for? So start with the clinical context on decision aid for elective surgery. So first of all, many of you I'm sure have developed tools and aids and all of this, so I don't want to belabor that. But number one, patients who are coming for a pre-operative visit, they're expecting to discuss the operation. They're not really there to pivot to a discussion of delay. They don't want to talk about alternatives. They're not there to talk about non-surgical interventions. They're there to buy their surgery and go. So, the idea of having a decision-making discussion inside of a preoperative visit, that's already kind of challenging. And to add to that, it's really compressed, right? You get 15 minutes, you're in, you're out. And that's the only visit you're going to have. Maybe you can call back, but you're probably going to get a nurse or an APP or somebody else who's going to call you back. So you get one opportunity. So the need in this space is for a decision aid that can communicate how these decisions can change outcomes in one easy to understand view. And this is where the implementation piece, I think, comes in. And to Christina's point, thinking about how is this actually going to roll out? And not just sort of let's make a tool and have it go out. So just to be clear, so we're kind of framing this appropriately. I'm drawing from a paper that was published in 2021. I think this is a good example just of how to break down elective surgery, what we mean by that. This paper sort of used COVID as a proxy for which surgeries were really considered elective during the pause on elective surgery. So always elective: cataracts, bariatric surgery, joint replacement. Mixed elective, things like a hernia repair, thyroidectomy, coronary artery bypass graft, and then urgent procedures, right? So in Christina's case, it falls in that category, but that there's these differences. So as we move through that and we think through that piece, what do we have to think about in terms of the design? Well, the first thing is the existing decision aids that have been in this space often feature complex numeracy. Anyone I'm sure here, or many of you maybe you've seen, raise your hand if you've looked at the NSQIP calculator in surgery, maybe-ish. Okay, so the NISQIP calculator is very classic, right? It's just enter a bunch of data points, spit out many, many risk bars. They're green, they're red, they're yellow. If you want to change anything, it's just like you got to go back and re-enter it and then put it back. And then the patient has to remember, oh yeah, I was like 20% on like the fourth bar down, and then I have to go back up, and very complicated. Doesn't show it all in one view. The clinicians and the patients are not really always involved in the development. This is kind of a well-acknowledged barrier. They're often relying on a predictive model where the surgeons were not involved in the design. So maybe they were involved in one or two steps, but not particularly engaged in that process. And historically, we've developed decision aids for surgical decisions, things like breast cancer, prostate cancer, others, but not necessarily for common elective operations, which increasingly are making up more and more of the surgeries that take place across the United States. So let's take the case of hernia repair and preoperative optimization. So over 500,000 patients a year undergo an abdominal wall hernia repair annually. Many of you, if you've not had experience with hernia, this is an interesting thing for me as a health services researcher. You know, when I started on my collaboration in this space, was like, hernias? Really? But it's surprisingly a very unique opportunity, because in a lot of ways, that preoperative consult is one that is an opening for other discussions and decisions that are connected to the more classical health behavior decision-making processes. Enter preoperative optimization. So this is an evidence-based practice where we're mitigating risk prior to surgery, things like smoking cessation, weight management, diabetes management. But 25% don't undergo preoperative optimization, even though we know that it reduces complication rates by as much as 40%. It helps us achieve reductions in cost, you know, all the things that we're looking for when we're trying to think about this type of question. So what were our objectives? First, we wanted to build a population-level predictive model with surgeons involved in the design. So a lot of times I get the question, so like, what's new about this? Surgery, like we've been doing this for a long time. What's new about surgery? What's different? Well, historically, this type of surgery, this sort of development process within this community is very challenging, and therefore these processes have not really taken place. It's a little different. You know, there's not, like I said, that sort of longer form opportunity to have that discussion. The decisions are a little bit more nuanced. You know, it's a little bit different type of clinician who's involved and engaged in the process. And as a result, a lot of the decision-making strategies and the decision-making tools that we've talked about in our community have not really broken through there in the same way. And if they have, it's usually not designed with all of these best practices. So one was to develop the predictive model with them involved. And two was to develop a decision aid that visualizes the changes and outcomes in one view. So one view. Especially for those who have low health literacy and low numeracy. And then here you can see kind of the sub-points that were important. Usable in a short clinical encounter, presents short and long-term risks. This is another challenge that oftentimes we're talking about a 30-day complication risk or something that's not necessarily an immediate thing is the concern. You know, what's the risk for regret or for, you know, belief that it didn't go well. Engaging clinicians in every step of development, and then quickly being able to accommodate changes in design that are recommended by surgeons and patients. So the tool I'm going to talk about is HEROIC, Hernia Optimization for Improved Quality of Life. We will do a live demonstration thanks to our friends at Russell Video, who've been very kind to be the typers. So we'll get there in one moment. But let me just walk you through a couple ways of how this was designed, and then I want to kind of look at it together. So first of all, I said the first objective was to build a predictive model with surgeon input. Again, it's not new to have clinicians involved in building a model. What is new is to do this in the surgical context and to have surgeons involved in every step of the process. So there's a paper that came out just about a year or two ago that outlined this 13-step process for how you can sort of robustly develop a predictive model. And we kind of adapted this process and said, all right, so we got 13 steps. We can identify about one or two, maybe three, where surgeons maybe have historically had some involvement, but we want to get them involved in every part of the process. Let's get them going on all different parts of this building so that we can make sure that when the model is used in the decision tool, the surgeons are willing to say, yeah, I buy that. And who developed that? Your colleagues did, which is a lot more trustable and believable. So we draw on data from the Michigan Surgical Quality Collaborative Core Optimization Hernia Registry. It's a population level registry that we collect here in the state of Michigan across 73 hospitals. We collect population level hernia and operative characteristics, very specific in this case, the fact that we have the data on nuanced hernia characteristics, which is different than some of the things that are collected in things like NSQIP, et cetera. We also collect one-year patient-reported outcomes, which I'll get to in a moment, another key piece which was informed by the surgeons who were advising on this process. So what does that mean that they were involved? I won't go into all the details, happy to take questions later or talk separately, but here's an example. So we built the model, right? And then we came together and we said, all right, here are 3 different versions of it. One uses random forest, one uses explainable boosting machine, both are machine learning type approaches, classification trees, et cetera. Great, except it's too noisy. Values are coming back in ways that clinicians were not expecting. And the surgeons were basically reporting, I'm not going to be able to do this with my patients because if somebody is losing weight and then they're going up in risk, this model is too sensitive to all of that. And the decision-making process and the explanation and like doing that in clinic, that's not going to work. So the question became, okay, if we're going to do that, then we need a model that's going to adhere and kind of work with the decision tool. So we were doing decision tool analysis as we were building the model. And so we settled on a generalized additive model because GAM allowed us to smooth this out and create a direction where we would be a lot more capable of having that decision tool turn out in the way that we were intending. Okay, the second objective, develop the decision aid itself. So here's where we started, right? The scientists got together and put this together. We started with a risk bar and we started to kind of like go through it. And so we sat down with all of our surgeons who were kind of working together with us on this process. And, we said, all right, what do you think about like color bar versus gradient? We're building on the existing literature, which all of you are familiar with on, the differences and whether or not it makes a difference, which it doesn't, spoiler alert, which you all know. But we started with this idea of like, what should the colors be? What should this look like? So we started here. We moved to the rainbow because one of the things that the surgeon said was, this cannot be a judgmental conversation. We don't want to tell people where they are, where they should be. So let's just make it a full spectrum, very kind of open and transparent what this should be. And so we ended up with what you see here, kind of like a rainbow type bar that has many different colors. So we started showing it to the different surgeons that we were working with across the state. And many reported back and said, you know what? It's too confusing. I'm like, all right, it's too confusing. Fine. What do you think? We want red, green, yellow, orange. Like, let's go to the classic traffic light presentation of this. Great. So we created this bar and we started to look at it again together. Showed it to more surgeons, and we were doing kind of iterative usability testing as we're developing this out with hernia surgeons across the country. And they all said, no, not the colors. So in our qualitative work and in our interviews, what we found was surgeons were saying things like, I don't want to have to choose which color they're in. If they're in red, what am I supposed to tell them? They're in red. Are they supposed to be in yellow? It's too alarming. So let's just stay with one continuum. So you can kind of see how this process is evolving, right? Because by the time we're reaching implementation of the tool, we've talked to and kind of engaged in this iterative process along the way. But that wasn't enough. Great to talk to the surgeons. What about the patients? So we started engaging the patients in the process. So we conducted a mixed method study. We took a random sample of patients that were drawn from just under 600 from an online posting here at the University of Michigan. The only criterion was that you had to be over 18. We had 30 patients as the target. They received an incentive. And we showed them some different versions of the graphic. And we started talking to them, what do you see here? So things that we wanted to draw their attention to, can you turn the units off? Can you turn the percentile off? Can you turn the probability off? What do you see here? What makes the most sense to you, et cetera? And we quickly started to gather feedback on how patients perceived this graphic and how patients were starting to think about what they saw in the decision aid. We also asked them, would you prefer the presentation as a bar versus would you prefer the presentation as an infographic or as an icon array, excuse me. And very interestingly, the patients all rejected the icon array and said, we want a bar. One of the patients, I thought was a very interesting comment in the interview, said, what is that? And I remember reading the transcript and I thought, interesting. So like we assumed that this was going to be what they would get at, and it was a hard no. We took this back to the surgeons and I said, well, let's see. What about taking this icon array and putting it into like the long-term outcomes? So we took it to a group of surgeons. Very interestingly, the surgeons came back, and to our surprise again, their response was very similar. What? And I said, no, it's an icon array. It's a what? It's an icon array. You know, like the thing you saw during COVID with the vaccines? No. That's very surgeon, and that's I appreciate the directness with my colleagues in that space. Very decisive. It was, no, we are not using an icon array. Okay, we are not using an icon array. All right, so we also started the process of looking at the color. So the surgeons had settled on orange, right? It was orange. That's like, it's like a mixed level risk sort of color and should be sort of there. Great. So we showed that to the patients. And of course, many of the patients said, orange, okay. Well, that's very alarming and that's very scary. And we don't like that color. How about blue? Okay, we're going with blue. So they liked blue better. We took that back to the surgeons. The surgeons found that blue was acceptable, and they appreciated that, which was great. And we went through some iterations of like green and turquoise and all of that. But I all my sort of storytelling aside, what you can see here is a deliberate process to take us through all the different aspects of the development, so that when it would be implemented, the tool would be believable, one that elicits trust, and one that would overcome some of the barriers that clinicians would say when they look at this and go, who on earth made this? Okay, here's the tool as it stands. We're going to do a quick demo because I think it's worth looking at here in one moment. But I want to just touch on something Christina said, which is super important. It's just very close to my implementation heart, which is, so you made a tool. Okay, great. Don't you think you should train people on how to use it? So we created a companion training called the Heroic Implementation Training, and we asked the surgeons to undergo the training. Very interesting process to get them to do it. We actually have a financial incentive right now through a P4P, a pay for performance incentive that Blue Cross Blue Shield administers through our collaborative. And we just said, you want the points this year? You got to take the training. That went very interestingly. But what we started to collect were data points on how confident they were that they could use it, how clear they were and confident they were on whether or not they could engage in preoperative optimization. Those data are still coming in and we're collecting them. But very importantly, we used the surgeons as the key stakeholder and voice. One of the first comments that we had from our advisory committee was, we want to be avatars. I said, okay, you want to be avatars. And remember, I have that filmmaking background. I was like, okay, that's interesting. But it's a very important point. We want to be avatars because we want to be the opinion leaders that are talking about this in our own voice to our colleagues about using this. And I thought a very insightful point to consider, which is who's the messenger of that training and who's explaining it. So it was a combination of the surgeons as avatars and other surgeons who were interviewed live, and sort of sharing with them both why we created this tool and how to use it. So with that, before I take questions, I want to do a quick demo. So are we good? I think we're good. I hope it'll work. herniacalc.com. Okay. So on this view here, we're going to enter a patient, all right? So we're going to enter someone who's 55 years of age, female. So let's change the toggle. 5'4", so 5 feet, 4 inches, weight of, let's say, 280 pounds. And then you can see here the toggle between BMI and weight automatically toggles. This was based on feedback that we need to have it be quick. Let's turn on the toggle for tobacco use. So there's smoker. We'll turn on diabetes with insulin. Okay, and their hernia size. This was one that we also worked on. Like, how do you define the hernia size? So hernia size of 3 centimeters. And then you can see here some other characteristics, which I won't turn on right now, but things like, did they have a previous repair? Are they planning to use mesh, et cetera? Okay, let's go calculate on the right. And so you can see here where the bar puts them. Very intentional. We don't turn the probability on. It's off by default. We can turn on percentile and probability at the bottom as toggles. If we want to just go through at the bottom there. Yep, percentile, probability if we want to, or the surgeon can. You can turn those off real quick. So toggle that off. Yep. But importantly, we show the one view difference. So let's go back on the left real quick. Just go change the number and weight to 150. Turn off tobacco use. And then on the right, click recalculate. And you can see the difference. So here is the decision-making process for preoperative optimization. What's the change? The change is the visual, not the number, the visual. And that's the discussion. The discussion is, how can we change your behavior? What represents a meaningful change? Now, I'll give you a quick, and then we'll open it up. Just to conclude, one of the things that was very interesting about this process was, as we began implementing this just about 2 months ago, the surgeons said, this is still too hard because those patients who have a very small change, it's not showing up as clear enough for us. So we changed the bar to be dynamic. So patients who had a risk of 0 to 5 have a bar that's scaled from 0 to 5 so that the difference shows up as even more magnified to help those patients who are lower risk to still see the value of preoperative optimization, even when their absolute risk is going to be one that is smaller. So we can export to a PDF for the results. That was another piece of feedback. We want one export, not 2 pages. It needs to be on one. And then if you just go up at the top to 1 year self-perceived recurrence, this is the last point, you can see here this presents in a more zoomed in view. This goes from 0 to 55, but in this case, it's a lower risk patient. So you can see here's the difference that they would experience if they're looking at the long-term outcome. In this case, the chance that they might perceive that their hernia has recurred. So in conclusion, and then I want to open this up for discussion for all of our presenters, I think what we've heard today is the importance of the decision-making piece, honoring and sort of being clear about the emotional aspects of this process, the importance of the implementation and how we consider what actually happens when we have a tool that's adopted and embedded into guidelines, and then how do we actually go about designing them and developing them with clinicians involved. So with that, we'll take questions, and I must say, I think for all 3 of us and all 5 of us, this has been so much fun and a real treat to be able to kind of work together and put this together for all of you. Okay, first question. And thank you, Russell Video, for the help with the demo.
This does not, oh, there it is on. Okay, great. Darren Zeranik from University of Michigan. And Michael, I want to make it clear that this is fantastic work and I love it. And I'm offering a critique as much as my own field as yours, but I think that what I see is missing here, because I'm a stroke neurologist and I get sent so many papers to review that say, we made a prognostic model and we added this one little thing and we made the ROC go from 82 to 85 and this is great. Yep. And I don't see as much work, and even this kind of, what seems to be missing is the patient voice and the information that they want and they need. And I understand why you focused on surgeons here, but I think, asking more fundamental questions about is that number that we're giving, is that really the one that's most important to patients and the one that they most need? And this is offered as a general critique, not as a specific one to the project you proposed, which I think is fantastic. So.
No, I think it's a great point. I appreciate the comment. This has been one of the big challenges, is what's the meaningful metric that we want to present? And that's why we have the 3 tabs here. The challenge has been collecting those long-term PROs has been one that's very, very complicated, because getting them at all is something that is predicated by whether you have them and then whether you can model on them. And I think that piece has been one that's challenging. So I appreciate the question.
Yeah, I just think that fundamentally, rather than saying these are the numbers we have and presenting the patients, start with asking the patients, what information do you want? What do you need to make those decisions? And then kind of predicting better models that can help them understand those meaningful outcomes.
Absolutely. And I appreciate it. I should be clear. these were chosen based on patient focus groups on which ones they would find meaningful. That's a good point.
Ankur Pandey at Harvard. Thank you so much for putting this together. All three of you are such wonderful presenters. There must be some selection bias here. And without naming names, one of you was at karaoke very late last night and still amazing job. So wonderful risk adjustment as well. This is fantastic. You walk through the steps of the development of this and the engagement, every step. Let me challenge you. I don't have a good answer for this. But when you talked about the surgeons wanted to shrink the probability space so they could see the differences sometimes, that can also introduce perhaps small differences looking artificially inflated or not. It depends.
Yes.
But let's say the stakeholder group, whether it's the surgeon, the patient, whoever, has an idea that could be kind of objectively wrong or debatable, let's say. What's your guidance for the give and take then in those scenarios where the researchers have our objective, rigorous hats, but we want this engagement and we want to be user-centric? How do you recommend we think about those kinds of scenarios?
It's interesting. I think that is actually the fundamental thesis of this session, right? It's that finding concordance, working together and working to develop together. How do you kind of get there? So I think the first question was great. Because it's like, why do you choose those metrics? Are those even the right ones to choose? And is that informed by those patients? And at the same time, to your point, being able to kind of speak to, what we might think is the appropriate way to view something or visualize something, et cetera. I'll tell you that part of this process, I think that has been most valuable is that intersectionality piece in the development and learning from each other. There's a lot of learning that I've had from the surgeons, and there's a lot of learning that they've had on, how far can you take something? When we started this initially, they insisted that there had to be 3 different bars based on hernia size. And when we ran the model many different ways through simulations, the answer was, it's just really not shaken out that way. So, I think a lot of that is the give or take. And that's why I think the partnership is really important and where that really becomes a central piece of the story.
So as someone who works with orthopedic surgeons, who would hate this, I think, one challenge that I think you're bringing, though, is the field differences, right? So not all surgeons are the same. Not all clinicians are the same.
Right.
And I was hoping to come to this session to hear you say, should we use a tool or not? And do clinicians really want them? It's the existential question, right? We're not going to solve that problem. But I think, I watched you do this and you did. Patients want something, surgeons want something. Gastroenterologic, colorectal type surgeons who are doing these, they want something specific, orthopedic. And so I think this is such a challenge in watching this and also thinking of the user-centered design perspective. And I want to be cautious. Not all surgeons are the same. I think that's my one comment. And all perspectives are not the same. But I would like to hear from the other clinicians on your panel too. Should we use a decision aid? And what is kind of, as you've worked with this presenter, and I know Anirban had a question earlier, and I want to make sure, because I want to hear it, and maybe it follows up on mine.
Is it aligned or separate? Okay.
I just wanted to ask, was there any evaluation done that whether it changed patient outcomes?
That's happening now.
Okay.
So the first step, and I want to open it up for our other clinicians to respond to, just 2 comments. One, we're deploying it so that we can see whether or not it does change patient outcomes right now. What I sort of described to you is the process of even being able to get to the point where the surgeons were willing to use it, because that's one of the big barriers. And that's something we talked about. It's like, are you willing to use this at all? And so that was sort of the intention. And then just to respond to the other point about are they all the same? This is for hernias, not for anybody else. We wouldn't generalize it. In fact, I have some other work I'm doing right now in thyroid cancer, not even touching this design, because it has nothing to do with thyroid cancer, not appropriate, and it's not guided by those principles. So I think it's a really important point to make, which is that who you are and which specialty you're in makes a difference. So, but I want to open up for Meredith and Christina to be able to respond to, if they'd like.
Yeah, if the question is, do I want more decision tools? No, frankly, no, I don't. But I think depending on how you think about decision tools, the answer might change, right? So what we have in palliative care, right? Our procedure, our intervention is like conversation. It's communication. So there's lots of tools to use to structure conversations, right? So there's the Serious Illness Communication Guide, which was developed at Ariadne Labs in Boston, which we teach and use extensively. We teach and use the Vital Talk structure. And so that's focusing more on the process instead of necessarily choice making, because choice making is highly context dependent, it's complex. There's, it is hard to boil down, but what we have sort of tried to focus on is that process of how are we eliciting values, how are we talking about choice making, the sort of first step of like, what is the decision and what are the options? There's nothing that I am aware of, and that's my particular area of research, is how palliative care helps the other doctors who are the ones who are going to be doing the procedure or sort of implementing the choice to come up with a decision and to come up with options, because it's a big part of what I do clinically, but it hasn't really been studied. So eventually, yeah, maybe there would be a decision tool, quote unquote, to have that kind of conversation, but it would look different than a traditional tool.
I would also just add that a lot of what's here was motivated by the idea of having that conversation, right? It was motivated by not focusing on numbers and saying this is your absolute risk and this is what it'll be. It's to have an open dialogue about like, why is it valuable to you based on those sort of difficulties in that visit? Why is it valuable to you to even consider a delay?
And I'll just try to make it as interesting as possible and go against what Meredith said. I think that I think we do need more tools in obstetrics, and this kind of gets back to what someone was asking earlier. I think otherwise, so often we can just go on gut and emotions, and it kind of does ground us. I think that it shouldn't restrict us. I think it's a great point. We need to make sure we're not being black or white with data, but finding a space for both where we can say, this is maybe your risk, or this is the risk of this. How do you feel? What are your values? And would that outweigh a slight increased risk? Another thing that I talk about a lot with patients is that these are all populations, and you're either going to have a complication or you're not. You're only going to have one of them. You're not going to have a 5% risk. And so thinking about how it applies, and this isn't you, but this just grounds us in the wild world of do you do this or not, and emotions, and then like you said, kind of finding that space where we can adjust for preferences and allow patients to tailor that, but still have the medical background and the data to inform decisions.
This is Hina Wasim, a neuro ICU physician. Kind of echoing some of the comments that have already been made from other physicians. I think that there are areas in medicine that desperately need things like decision aids to help, like in regards to neuroprognostication, where there's a large deficit. So I think it depends on the area of medicine that you're actually in, and then also the patient populations that you're dealing with. And their literacy and location, even within the US, can really change how patients might perceive this. This was done in Michigan, but I'm just theorizing or imagining how this could change how patients might want to see this data in different urban or rural settings, and based on literacy. It could vary just even across the US. So unfortunately, I think there's a lot more variation and on both sides than I think we realize sometimes.
I think it's a really important point, and one that's really critical here, which is that we can't just draw the assumption that one aid is everything. That we have to be able to tailor them, that we have to be able to find ways to make them reflect as much as we can the different values and the preferences, and start with something and then iterate on it.
There's someone there. Couldn't see your hand.
Thank you. Michael Rothberg, Cleveland Clinic. I am in awe of the way that you did this whole thing. I think that's amazing. What I'm a little bit concerned about is it doesn't really seem like the goal of this is to help patients make better decisions. It seems like the goal of this is to convince patients to do what the surgeons want them to do. The surgeons want the best possible outcome from their surgery, but they don't have to do any of this stuff like lose 130 pounds. And so that's why when the absolute difference is very small, and the patient might very reasonably say, oh, for that small difference, I'm not willing to do this. They want to make it look larger so that the patient will do it, so that the patient gets the best possible outcome. And it just seems kind of paternalistic. So I don't know how you felt about being part of that process. And you were a little bit co-opted by the surgeons to create a tool that maximizes what they want rather than necessarily what the patient wants.
So it's an interesting question. It's a very important one, and one that as a health services researcher I had to wrestle with. Right? It's like how do you kind of reconcile that? So the first step, in my view, is we have to get in the room. Right? We got to be in the room and have built trust with our clinician partners, so that they are willing to work with us on something. I don't know that this is where this would end. I don't know that this is where this would stop. If we were to continue to iterate on it, I'm not sure that this is what it'll be. We're going to see kind of what the data show us on the outcomes. One of the things that I was very pushy about was keeping the units turned on, because at the very least, we have to be able to be transparent and clear with the patients. This is what the risk is, right? If it's a 3 or 4%, and one of my colleagues actually said to me, that's been his hardest part of his decision discussion about this is they see any number, 5, 6, 7%, and it's like, you know what, that's acceptable for me as the patient, and I don't want to do, those behavior changes. But up until this point, there had not really been a way that they had been able to successfully even broach that conversation, and this was sort of their first step and our first step to try and create something. So I think that what's great about being able to present here and kind of and have you all kind of talk to the three of us is sort of to be able to have that thoughtful dialogue on, like what is and isn't appropriate, what should or shouldn't be the right way forward, and see, where that lands. But I think that the trust building piece has been key to be able to really ask the question of, can we start with something at all?
We're out of official time, which seems crazy. I feel like it went by really, really fast. But I know I'm around and not heading out anywhere. So happy to talk more.
Thanks for
Thank you all
sticking
very
through
much.
to the
Thank you.
end.
Last session.